Bismillahirrahmanirrahim. This presentation is regarding grossing of a pathological specimen. When a specimen is received in a pathological lab for giving a diagnosis, particularly a microscopic diagnosis, the first step is grossing of the pathological specimen. Now, what do you mean by grossing? There are a number of things which are important in grossing. We'll go one by one. Number one is the specimen should be preserved in formalin. Number two, identification of the organ which has been sent for examination. Number three, noting the architecture, consistency of the specimen. And number four, measuring dimension. Next, number five, cutting the specimen to see the interior of the organ. Number six, taking small pieces of representative tissues that can sit comfortably in the cassette. Number seven, labeling the cassette with patient's file number for proper follow-up and reporting. And once done, close the cassette with a plastic lid for further tissue processing. Now we'll go one by one, and step number one is formalin. So whenever you receive the specimen in a container, it should contain formalin. Now formalin is very important for preserving the tissues. If the tissues are not preserved in formalin, it will get petrified and you won't be able to make a diagnosis. So the first important step is whenever a specimen is taken in an operation soon after surgery, and before sending it to the lab, always preserve it in the formalin and then send it in the container containing formalin. So that is very important, because if the formalin is not sent, the whole exercise would be futile and you won't be able to make a diagnosis. So the next step after formalin is identification of the organ. Now this is a specimen which is easily identifiable because it has got uterus in the middle and two masses on either side, and there is a connecting link. So the masses on either sides may be ovaries. They do not look normal ovaries. They are big masses, and the connecting link over here is the fallopian tube. Now this is a specimen removed at surgery during removal of the uterus, fallopian tube. So it's a bilateral salpingo-oophorectomy with hysterectomy. Easily identifiable. Sometimes it can be difficult to identify. So what is important is having a clinical information. Clinical information is very important, which is given by the clinicians, by the surgeons, by the physicians before they send the specimen for diagnosis. So that is very important, clinical information. And the clinical information may contain a provisional diagnosis or may even contain a final diagnosis. And it may also contain investigation which have been done. What were the imaging techniques? Were X-rays done, radiological images? Were the CT scan done? Were MRI done? Or what other investigations, what the lab investigations? So The more clinical diagnosis, the more clinical information you have from a clinician, from a surgeon, the better a pathologist would be able to give a diagnosis. So that is very important. So after you've identified this organ and gone through the clinical information, the next step would be measurement. Measuring the size of the uterus. Here we are measuring the size of the uterus. That's the length of the uterus. So 3 dimension: length, width would be like this, and the depth. So you measure the uterus size over here. What is the length of the uterus? What is the width? What is the breadth? Similarly, you can measure the ovaries even. What is the dimension of the ovaries? And you can measure the fallopian tubes, the length of the fallopian tubes. So measurement is very important, because if there are abnormal measurements, that means there may be some pathological features which are apparent. So here, after measuring, this is the measurement of the gross specimen. But you will continue measuring once you have cut open the tissues. Once you have slit open the uterus, you will still measure the inside of the uterus, the size of the endocervix, the size of the uterine fundus, the size of the myometrium, and so on. So the measurement continues throughout grossing process. So after you have measured the tissues, then next comes the cutting open the specimen. Now here we are trying to slit open the uterine tissues into 2 parts. We have inserted an instrument over here, forceps, in the cervix, and we are cutting through the cervix, and there will be an anterior part of the uterus and there will be a posterior part of the uterus. So the uterus is being split into 2 parts. So similarly, when you want to open up the ovaries, you will again split up the ovaries into 2 parts and see the contents. So important thing is cutting the specimen properly so that you do not injure. If there is any pathological inside, you do not unnecessarily injure too much of the tissues inside the cavities. Now after cutting off the specimen, here you see the uterus has been divided into 2 parts. One is the upper part and the other one is the lower part. And you can see the cavity of the uterus. That's the cervix. That's the endocervical canal. This is the myometrium over here, and endometrium would be here. Lining the cavity would be endometrium, and the perimetrium would be outside. So you again measure the width of the myometrium, you measure the length of the endocervix, length of the uterine tube, and so here you do not see much of any pathological finding. There is no gross abnormality over here in the uterine cavity. So that is uterus split into 2 halves. Similarly, here you got the ovaries, cutting open the ovary, splitting the ovaries into 2 parts, one above and one below. And once you cut open the ovaries, you are looking inside the uterus, inside the ovary over here. And the findings over here is very much abnormal. What you see inside is yellow material, and there are some hairs, tuft of hairs inside. So this uterus, this ovary, which was enlarged in size, which was semi-solid because of this contents which are yellowish and semi-solid in nature, and these are hairballs. So these are very typical findings of a mature teratoma. Mature teratoma has got the lining of the ovary is skin lining, lined by skin, epidermis, and all the dermal appendages. And because of the skin lining, there are lots of hair follicles. So this yellow material is sebum from the sebaceous glands, and these are hairs which have fallen off from the hair follicles, and they have accumulated because of the closed contents of the ovary. So this is a typical finding of the mature teratoma. Mature teratoma can contain other tissues as well. Besides hair follicles, sebum, it may contain a molar tooth, it may contain some bony tissues, it may even contain thyroid, because teratoma arise from more than one dermal, from more than one congenital lining, mesoderm and epidermis. So that is typical of mature teratoma. So even before you have done any histological examination, the gross findings are so typical that you would be very confident in writing that this is a mature teratoma. Now, after you have cut the tissues, open up the tissues, you take small biopsies, samples of the from the represented tissues. Here we are taking a small sample from the cervix. There is no gross abnormality, but we want to make sure that there are no microscopic changes over here. So when you are taking a cervical part, it's important that you take junctional tissues as well, ectocervix and endocervix together. So because most of the changes of malignancy which appears earlier on is at the junction between the endocervix and endocervix. So you take a small pieces from cervix, you may take some tissues from the myometrium if need be, or similarly you can take tissues from the over here from the ovary to make sure that the skin lining is over there. So taking small biopsies is very important, and after you've done a gross examination, you take biopsy and you put them in the cassette. This is the cassette, which are the small biopsies are put in the cassette, and you can see several cassettes over here where biopsy specimens are being put. Here we are there are at least 4 cassettes over here with different tissues being kept in, and it's important to label them. Now these are being labeled and by patient's file number and by the site from where the biopsy has been taken: 2721A, 2721B, 2721C, 2721D. So these cassettes must be labeled properly with the patient's file and from the location where the biopsy has been taken. And once you have labeled them, you close them with a lid. So that's the final appearance of the cassette. So here the grossing ends, and then the tissue processing begins. So we'll talk about tissue processing in the next video. Thank you very much.